Hello, my name's Olivia Hughes. I'm a fifth year medical student at UCL Medical School, and my presentation today is on myocarditis. So we'll start with a brief overview of myocarditis, work through a case example together looking at presenting symptoms, investigations you would order, expected results, management of the patients, and complications that come with myocarditis. There'll then be an SBA and a summary. Myocarditis is defined as inflammation of the myocardium. This is commonly associated with pericardial inflammation as well. So myocarditis is caused by inflammatory cell infiltration, and this causes degeneration and necrosis of the myocardium. You can have acute or chronic myocarditis, but we'll be focusing on acute presentation today. And in terms of causes, you can split them into infectious and non-infectious. So looking at infectious, most commonly viral myocarditis, but you can also have bacterial or spirochetes. And then non-infectious, you're looking at drugs, toxins, and immunological causes. So I've included quite a detailed table of all the different causes. So you can see at the top, idiopathic is accountable for 50% of cases. Then we have viral, which is most common after idiopathic. And so there's a wide range of viruses that can cause myocarditis, most commonly adenoviruses, influenza, hepatitis, tends to be B and C, HIV, HSV, and so on. Bacterial, you've got your staph and your streps, and all the others listed there. Spirochetes is leptospirosis and syphilis, and then you can also have protozoa causing myocarditis. And then in terms of the non-infectious causes, so here's a list of drugs that can cause myocarditis, so penicillins, your sulfonamides, chloramphenicol. You then have cyclophosphamide and trastuzumab, which are the anti-cancer drugs, anti-epileptics, so phenytoin and carbamazepine, and then other, so methyl-dopa and spironolactone. In terms of toxins, cocaine is a big one, and then also lithium, alcohol, lead and arsenic. And then immunological, your classics, so SLE, rheumatoid arthritis, sarcoid, Kawasaki, scleroderma, and also heart transplant rejection. So I've included this purely for you visual learners because I quite like diagrams to visualise what's going on. So you can see in the top picture we have normal heart muscle and normal myocardium, and below myocarditis, so you can see the infiltration of the immune cells, and you can also see damage and breakdown to some of the myocytes. And now on to our case example. Right, so imagine you've jumped forward a couple of years, you're in FY1 in A&E, and you open the cubicle door and Mr. Johnny Snow is on the bed. 35-year-old male, he's presented with acute onset of chest pain. He says he feels like his heart is racing, he's sweaty and he feels nauseous, but he has not vomited. So, quick examination, you see that he's sweaty and he's clutching at his chest. His heart rate is approximately 100 beats per minute, rest rate of 18. His pulse is regular and it's a good volume. You can hear heart sounds 1, 2, and there's an added S4 sound. His chest has good bilateral expansion, there's normal air entry both sides, and there's no added breath sounds. His temperature is 38.4 degrees centigrade. So what more would you like to know from this history? Just have a think about that before moving on to the next slide. Hopefully you managed to jot down a few extra questions that you would like to ask. So Mr. Snow says that he's had a 2-day history of a sore throat, runny nose, fever, and just generally feeling unwell and tired. He says the pain in his chest started around 2 hours ago, but it doesn't radiate anywhere, doesn't vary with movement. He took some paracetamol, which hasn't helped, and he's never experienced anything like this pain, so it's a 10 out of 10 severity. He has no past medical history and is currently on no medications and has no known allergies. There are no family history of any heart conditions, so in this you specifically want to be asking for a history of HOCM and any myocardial infarctions under the age of 50. He's a non-smoker, has never used drugs and drinks about 2 glasses of wine per week, and he works as an investment banker in the city. So based on this, what investigations would you like to order? So beginning bedside, I'd want to order an ECG. You'd want to order bloods, full blood count, CRP and ESR for non-specific markers of inflammation. You'd want to do a serial troponin to rule out myocardial infarction, but you also get a raised troponin if there's any damage to the heart muscle. An NPA, so this is a rapid influenza diagnostic test, and it's only 30 minutes to get a test result. You'd want to do some viral serology, so this uses antibodies to detect the antigens, so such as CMV, EBV and hepatitis, but it takes 48 hours for a result. But the result of this helps you to discriminate an acute viral infection from something a bit more chronic like B19. You'd also want to do an echo, so this looks at the function of the heart, and cardiac MR if they're clinically stable. Results you would expect to see. So on an ECG, the most common things you'll see is a sinus tachycardia, non-specific ST changes and T-wave inversions, and you may also see atrial arrhythmias, transient AV block and QT prolongation. In the bloods, you would expect to see a high white cell count with the infection, and you would tend to see high lymphocytes in a viral infection and neutrophils in a bacterial. As I said before, you would get a raised CRP and ESR, which are non-specific inflammatory markers. Only a third of patients will have a rise in their troponin levels, so you actually probably would expect it to be normal at this point. And you may also see an increase in the IgM serology. On an echo, you would see regional wall abnormalities, and I've got an echo to show you later on. And in a cardiac MRI, you would visualise the inflammation and the damage. The gold standard for myocarditis is an endomyocardial biopsy, and this quantifies inflammatory cell numbers, characterises infiltrated immune cell subtypes, detects and quantifies different virus types and loads. Right, so Mr. Johnny Snow's results are back. In his full blood count, we can see that he's slightly anemic with a red blood cell count of 118. His white cells are raised, as we anticipated, and 28% lymphocytes, so this is suggestive of a viral infection. And his platelets are also slightly on the low side. His CRP and ESR are both slightly raised, but CRP tends to remain below 50 in a viral infection. ESR should be under 15 in a healthy male, so we can see that's slightly raised. The creatine phosphokinase level, so this increases if there's damage to the heart, brain or any muscle, and we can see that, again, this is increased. It can also be falsely increased, just as a side note, by activities such as vigorous or endurance exercise, so that's something to bear in mind. His troponin is very, very slightly raised. We'd expect that to be below 4. But you would want to do serial troponins as you would with ACS. So we'd repeat that in 6 hours. His RIDT is positive. Serology, we're still waiting on results. His ECG is on the next few slides, and we're waiting on the endomyocardial biopsy. So I don't know about you, but I always find ECGs fairly tricky. So I've included a few slides with different ECG tracers from myocarditis patients, but just focusing on this one in front of us. So comparing it to the normal. So I always begin by working out the rate. So I count the number of peaks, and as a strip is 10 seconds long, you just times this by 6. So we can work out it's approximately 96 beats per minute. You can see here that there's QT prolongation, so remember anything above 450 milliseconds is prolongation of the QT interval, so we can see that it's grossly enlarged here. Also, if you look along the very bottom strip, you can see that not every QRS complex is associated with a P wave, so some of those P waves are probably hiding in those QRS complex, so this is suggestive of an AV block. And here is just a breakdown in each lead what you might expect to see. So you can see there's T-wave inversion in the limb lead 2. V1 shows another example of QT prolongation, and we can see in V3 that there's ST wave elevation. So the next couple of slides are just a couple more traces of myocarditis patients. So you're mainly seeing sinus tachycardia and just widespread ST changes. So have a look through those in your own time. I've included these echoes purely for interest and because I find them quite cool, but it goes beyond what we would need to know as a medical student. So in the top left-hand corner is a normal echo, and then the one in the bottom right is what you would see in a myocarditis patient. So echoes use sound waves to look at the heart, and we can determine the function of the heart. So you can see in the bottom right-hand one that it's hypokinetic because you get dilatation of the chambers, and also the contraction is not in unison, so you don't get blood pumping out of the heart efficiently. Remarkably, you've got the results from your endomyocardial biopsy already, and you can see from the image the infiltration of the immune cells. So they're the purple splodges, and the pink tissue around it is the myocytes. So drawing all of the above together, what is your diagnosis? Well, it's obviously going to be myocarditis because that's what the presentation is on. And because of the positive IRDT and the 2-day history of coryzal symptoms, you would suspect a cause of influenza virus. In terms of management, I've split it into supportive and medical. So supportive is obviously rest, fluids and analgesia, and also to avoid exercise because this can precipitate arrhythmias. And medical management, you're going to give steroids to reduce the inflammation of the heart muscle. You want to treat the underlying cause, so antibiotics or antivirals, if it's an infectious cause, and treat any arrhythmias and heart failure. So you'd be thinking about ACE inhibitors, beta blockers, furosemide to offload the heart. You'd also want to consider anticoagulants, so if you can see from the ECG that there's arrhythmias such as AF, you'd obviously want to anticoagulate them. The prognosis is that 50% will recover within 4 weeks, but 12 to 25% will go on to develop dilated cardiomyopathy and severe heart failure. And this dilated cardiomyopathy can occur years after apparent recovery, so it's a really important episode in someone's if you're ever taking a cardiac history, if they've ever had previous episodes of myocarditis, that's a really important thing to pick up on. Complications, as we've just touched upon, is heart failure secondary to dilated cardiomyopathy, which is most common. You can also have myocardial infarctions and strokes, arrhythmias, and sudden cardiac death secondary to severe arrhythmias. SBA time. So a new case, we now have Margaret Sutton, a 55-year-old lady, presenting with a 3-hour history of acute severe chest pain. An ECG shows tachycardia and widespread ST changes. Your team suspects myocarditis. What is the most definitive investigation for diagnosis? Serial troponins, viral serology, endomyocardial biopsy, an echo, or the ECG changes alone? Hopefully you went for 3, endomyocardial biopsy, but we'll talk through the other answers and why they would be good but not the most definitive investigation. So serial troponins are important as an MI needs to be ruled out. Also, a third of patients will have elevated troponin, but it's not diagnostic for myocarditis. Viral serology helps to discriminate between acute infection or reactivation if it's a viral cause of the myocarditis, but again, this isn't diagnostic. So an endomyocardial biopsy, which is the correct answer, as we said earlier, it quantifies inflammatory cell numbers, characterises infiltrated immune cell subtypes, detects and quantifies different virus types and loads. So that is your most definitive investigation. An echo, again, is important in the workup as it shows structural changes and the function of the heart, but isn't going to show you the cause. And ECG changes alone are not enough, as this could be caused by several things. So pericarditis, PE, hypertrophy, hypothermia all cause tachycardia with widespread ST changes. So that's why 3 is the correct answer. Well done, you've made it to the end. I hope that was useful for you. So just to summarise, myocarditis is inflammation and destruction of the heart muscle, and idiopathic and viral are the most common causes of this. Endomyocardial biopsy is the gold standard diagnostic investigation. Management is supportive, steroids, treat the underlying cause, and treat any heart failure or arrhythmias with ACE inhibitors, beta blockers, and furosemide, and consider anticoagulants if there's arrhythmias. And the most common complication is heart failure secondary to dilated cardiomyopathy and ongoing arrhythmias. Thank you for listening. Here's some extra resources that you might find useful to read around the topic.